شعبولة.
شعبولة ماما هيقولي أنا اسمي شعبولة.
You say night time.
Oh, شعبولة. أنتي حطيتي بالي.
شعبولة. شوف.
Next parent 13. أنا 11 ما يخصني. 2 years.
يسأل.
മനസ്സ് എങ്ങനെ ഓഡിയോ എങ്ങനെ ജോയിൻ ചെയ്യും ഇപ്പൊ അവിടെ കിടക്കുന്നു.
Okay, hello everybody. Good evening all. I'm Dr. Rola Dehneem. Welcome to our sixth Derm Education meeting. To all of you and to our new members who join us for this meeting, please just make sure that your mic is muted before we started. And just a few 2 points before we start. We have sent a survey through your emails. Just kindly take a few minutes to give us your feedback of the lectures and of the timing of the lectures. That will give us a few points toward the future meeting as well. And as you all been noticed that you have been added to the Microsoft team, and that's a platform for everybody to share and discuss all the clinical cases. If you have some of exam questions that you want to share, some interesting articles, and that will be for everybody. So let's begin. The lecture will be divided into 2 parts. Dr. Amin Al-Awadi will give us the first part today, and it will be the derm path with inflammatory dermatosis part 1, and it will be followed by brainstorming cases that I will give you after Dr. Amin. So Dr. Amin, all to you.
Hi, yes, thank you. I hope everyone can see my screen now. We'd like this to be a very interactive session, the more you interact, the more we can learn. Otherwise, please keep your mics on silent, like Dr. Alba said, so that everyone else can focus on the lecture and benefit from it. Okay, so let's go straight away to the first slide. So this is going to be inflammatory dermatoses. We're hoping to finish them in 2 presentations, but if not, maybe we can make a third. So first case, can anyone tell me what we're looking at here? You can say it with the audio better than you can write it through chat, but it's better to say it through audio. So I can hear.
There's a lot of spongiosis.
So there's a lot of spongiosis, yes.
Vesiculation in the epidermis. You see like the spongiosis pulling the keratinocytes apart.
Okay. So if you say this is spongiosis, would you think this is an acute, subacute, or chronic spongiotic
acute,
process?
very, very acute.
So very acute for 2 reasons. First of all, because there's much more, there's a vesicle or even almost near to a bullae here forming. Second of all, the spongiosis is much more than the perikeratosis. Let's go and look at the horn here. You can see it's still a basket weave horn, which implies a very acute process. Some like to call it the this week sign, because whatever's happening is happening this week. It's very recent. So you can see here the cells are being next to the blister. It's always a good clue to know the cause of this blister. You can see a lot of spongiosis around the blister, which culminated in a separation here. There's fibrin inside the blister, a little bit fibrin. The cells would always tell you a hint as to what the cause of the blister is. Let's say, for example, there was a lot of neutrophils inside. We'd think this is like a pustule or an infection or psoriasis, for example. And when there's a lot of eosinophils, you might think of and less spongiosis, you might think of a blistering disease, for example. So going back to spongiosis, if we surmise that this is spongiotic derm, and this is the first condition I wanted you to know, is it always easy to differentiate what kind of spongiotic derm it is? Let's say, for example, contact dermatitis, atopic dermatitis, dyshidrotic, or steatotic or nummular?
No.
It's very difficult, and in many cases it's impossible. But sometimes there could be hints. Like in this case, for example, what kind of cells do you see a lot in the cavity? They're not lymphocytes as much as there's another type of cell that's overabundant here. Can anyone tell me what it is? Look at this cell here.
Yeah, are these plasma cells? It's kind of like a
you might think so, but it's more bean shaped. It's not.
Oh, okay.
So it can have this other cell also can have a nucleus on the side, and it's more bean shaped, as you can see here. It's present almost everywhere in the blister cavity. So what kind of cell is this, and what do you think is going on? So someone in the chat, Michal, said this Langerhans cells, which is correct. So there's a lot of Langerhans cells and some eosinophils, if you notice on a little bit on the top and a little bit in the dermis as well, some eosinophils. So if there's a lot of Langerhans cells in a spongiotic dermatitis, would you think of something more likely than the rest? Anyone? I would think of contact derm. Remember, what's the job of Langerhans cells? They present the antigen. So when you have a contactant in coming across the skin, the cells that are going to first face it are the Langerhans cells. So when you have a lot of Langerhans cells, you think of it more of a contact derm, and certainly the eosinophils help us more to point out as an allergic contact dermatitis. Okay, next case, as you can see here. Let's focus on the epidermis. What's going on here?
So there's more spongiosis. It's not as
there's
severe
again
as the other one.
spongiosis. And how? Do you want to comment on the horn?
There's parakeratosis, there's some hypergranulosis. So this is more like subacute.
So this is more of a subacute spongiotic derm. So the difference from the one we saw earlier is that the spongiosis is certainly less. It's there, but it's certainly less. The horn is starting to take shape as a parakeratotic horn and starting to be more compact, which tells us this is more of a subacute spongiotic process. Again, is this atopic dermatitis? Is it chronic subacute contact dermatitis? Is it discoid or steatotic? It's very hard to make a difference. I mean, steatotic, we can differentiate it if there's a lot of vessels in the dermis, like features of stasis, but we don't see it here. But generally speaking, it's hard to differentiate between different spongiotic processes. But what I wanted you to know from this slide is how a subacute spongiotic derm would look like. Next slide. Which is taking time for some reason to load. I don't know why. Okay. Yes. So we have a large shave biopsy here. Can anyone tell me what we're looking at here? So this is more again of inflammatory rather than neoplastic conditions. So don't think of like seb cares or any of those or warts, because we're not talking about infections. So what do you see here? Anyone tell me what we're seeing here in the upper dermis? Someone said we see hypergranulosis. MK, yes, we do see a lot of hypergranulosis. There's capillaries, and how are the capillaries oriented here? I can't hear. Whoever's speaking, I cannot hear. So someone here said LSC prurigo nodularis. So yes, we see, and someone else said longitudinal. Ahmed says longitudinal, which is correct. So okay. So the correct answer is LSC versus prurigo nodularis, but the distribution, the plaque-like nature, and that the fact that it doesn't look very nodular tells me more that this is LSC. But yes, it's always hard to differentiate between LSC, which is chronic spongiotic derm, or prurigo nodularis. Sometimes it's hard to differentiate between the two. It's just the general outline of the lesion that can help us here, because when I look at this on pathology on low power, I can tell you this is more like a plaque rather than a nodule. So let's go deeper to see the features here. You can see a compact stratum corneum, which is the result of a long-term spongiotic process and long-term rubbing of the skin. There would be scattered perikeratosis, not very confluent. Some areas yes, some areas no. The granular layer would be thickened at certain areas, as you can see here. And the dermis would give me some features of scarring, because you remember the chronic rubbing of the skin is going to cause us to have thickened epidermis and scarring of the dermis. As you can see here, similar features that you would see in a scar. As you can see here, the vertical blood vessels and the horizontal collagen fibers and fibroblasts would be found here. So these are the features of chronic spongiotic derm. I have to admit there's very little spongiosis to see here. So there's always stages when you go really chronic. All you're going to see are the feature the LSC features, and less so the spongiotic features of a chronic spongiotic derm. Okay, moving on to our next slide. Let's see here if anyone can tell me what's going on here at let's say medium power, not very high power, not very low power. Something very striking is I can see here with the rete ridges. Who can tell us what this is, or at least comment on the findings that we can see here rather than the diagnosis? So 2 people say psoriasis. You guys can, if you want to share with the mic and explain to us why you went straight to the diagnosis of psoriasis. So MK, yeah, that is correct. So we can see club-like regular rete ridges, number 1. So there's regular rete ridges. No mind this area. There's always going to be some aberrations. But generally speaking, we have regular club-shaped rete ridges, which is very obvious here. What else can you see here? What is this? Can anyone say?
Dilated blood vessels.
Dilated blood vessels in the upper dermis, correct, which is also another feature of psoriasis. Someone said monomicroabscesses, which is over here, correct, yes. But what I was talking about here is the thinning of the suprapapillary plates, which is a common feature in psoriasis. As you can see here, see the dermal papilla goes really close to the stratum corneum, which is the reason why we have what we call Auspitz sign, because when you pick out the stratum corneum and part of the little epidermis comes off with it, and you got your superficial dermal blood vessels, the patient will start to bleed. Another very striking feature here that we see is the neutrophilic parakeratosis. So other than the fact that there's a confluent parakeratosis, when it's studied with this much neutrophils, the differential diagnosis starts to be very, very narrow here. So neutrophilic parakeratosis can be found in very few conditions, which we'll see some of them later on. But psoriasis is definitely one of them. And when it's really confluent, the diagnosis starts to become very straightforward. So this is a condition of plaque psoriasis. Again, club-shaped rete ridges, thinning of the suprapapillary plate, dilated vessels in the papillary dermis, confluent parakeratosis, neutrophils scattered all over the stratum corneum, very little spongiosis. So all these features are of psoriasis. Moving on. Can anyone tell me what this is or what we're coming across here? No one? Okay. So again, if you can see here, we've got our, so someone says the psoriatic eczema versus tinea. Okay, so let's see. First of all, there are regular reteriges, again, like we saw earlier with psoriasis. There is somewhat, and this is an acral location, okay? Um, Other than that, there's a pretty confluent perikeratosis. Don't mind the upper layer because the upper layer is what's been going on last week. Today and yesterday and this week, we have this perikeratosis. So what's going on is an acute process, not a chronic process. It's more of an acute process. You see confluent perikeratosis. Again, hypergranulosis, which I don't think I mentioned in the previous lecture, and it's very important to mention with psoriasis. Okay, there's some area here with the normal granular, but this is away from the pustular lesion. When we go to closer to the pustular lesion, you can see a confluent perikeratosis and diminishing of the granular layer. And again, there is still a lot of neutrophils in the crust, as you can see here, which is again very distinctive of psoriasis. So what we're seeing here is a large pustule in developing in a patient with psoriasis. So what we're seeing here is a case of pustular psoriasis. If you notice, there are many of the other features that we saw with psoriasis. Little spongiosis. If you compare it here with the eczematous condition we saw earlier, adjacent to the pustule, there was much more spongiosis in the acute spongiotic case, which we do not see in this patient. So confluent perikeratosis. Always remember the chronicity of the lesion and how to interpret the findings. So the epidermis grows outwards and then the stratum corneum grows outwards. So what we're seeing here in the top is all the old stratum corneum. The new stratum corneum is starting to develop a neutrophilic crust all over, which indicates an acute process. And when it comes to psoriasis, the acute types of psoriasis are mainly the erythrodermic and the pustular psoriasis. And because of this large pustule, we know which one this is. Okay, so this is pustular psoriasis. Moving on to the next patient. What can you see here? What are we seeing here? Come on, guys, let's make it more interactive, especially with the audio. I want to hear your voices. What are we seeing here? So Michal says this is a subcorneal pustule, which is absolutely correct. So when we talk about subcorneal pustules, there's a group of differential diagnosis we know. So which one of them will you think this is? So subcorneal pustule, there is no regular elongation of the reteriges, and the pustule is very high up in the epidermis. So it would be less likely to be, for example, psoriasis, even though it could be, but it's not. And what infiltrate are you seeing in the dermis here? What are the cells here?
There are a lot of neutrophils in the.
There's a lot of neutrophils, correct, that are causing an almost vasculitic process. If you can see here, the dilation of the endothelial cells and the fibrinoid increase in size and degeneration of the vessel wall. So what we're having a subcorneal pustule with almost a vasculitic process, a lot of perivascular neutrophils. Let's see, some eosinophils as well, as you can see in this area. Psoriasis are not going to give me that. What other conditions do you know can cause a subcorneal pustule? So AGEP is 1, Sneddon-Wilkinson is 2, SSSS is 3, correct. Candida is 4, you are all correct. And Impetigo, you're all correct about this, definitely. So let's dissect them one by one. What kind of acropustulosis do you mean, MK? So AGEP is correct, and infant acropustulosis, okay, correct. So does this look like acral skin to you? Now you know the areas of the skin. This does not look like acral skin. So this is the first we can toss out as a differential. But no, you're correct in terms of a differential. So first we can toss out is that. Okay. Second of all, the stratum corneum in candidal infections, usually Candida similar to psoriasis, it will give us a parakeratotic horn. So this makes it less likely to be Candida. Number 3, SSSS. SSSS, you need to know that it has a minimal infiltrate. I cannot say that this is definitely not it, but it is highly unlikely to be SSSS because remember, SSSS is just the toxins of the staphylococci going around the body and cleaving the skin. There's not much inflammation. There's not much organisms. So the pustule will be kind of like empty with only a few neutrophils. So we can toss that out also from the differential diagnosis. Um, so Snedden-Wilkinson is a good differential diagnosis, and this could definitely be Snedden-Wilkinson. But what makes Snedden-Wilkinson less likely, and same with impetigo, which it could also be impetigo. What makes Snedden-Wilkinson and impetigo less likely is that if you can see here, there's a mix of patterns. We do have a subcorneal pustule. We have quite a lot of spongiosis. I have to say, more than I would like to see with subcorneal pustular dermatosis. And there's vasculitis, or like almost, yeah, you can see vasculitis. Psoriasis, for example, can give us subcorneal pustule and pustular psoriasis. But an interesting fact is, as much as psoriasis likes to be pustular and have neutrophils in the stratum corneum, if you go down to the dermis, you would definitely see no neutrophils in the infiltrate, which makes, for example, pustular psoriasis less likely in this picture. So of all the features we talked about, drug reaction starts to become much more likely with this patient. And another feature that makes it also likely to be a drug reaction or age-up is the dyskeratotic keratinocytes, which you can see in all over the dermis. There's a lot of dyskeratosis. If you go around here, a lot of cells are undergoing necrosis, and the dyskeratosis is starting to appear pink. They're starting to clear the cells. So these are all features of age-up rather than the other things. So to summarize, age-up, subcorneal pustules. If you can see how acute this process is, there's no parakeratosis in the stratum corneum. Even though I have to admit, and I would expect to see more, but you can see here the cortic keratinocytes undergoing apoptosis. Spongiosis, vasculitis in the dermis. Always think of two things when you see mixed infiltrate pattern. When you see mixed infiltrate, like vesiculation and vasculitis, or psoriasiform and interface, or spongiotic and vasculitic, always think of two entities that give you always mix of patterns. Think of syphilis and think of drug reactions. These two entities will always give you a mix of patterns rather than one thing. Okay, moving on because we're running out of time. Let's see what this guy has. What do you think this is? I can't hear anyone, but someone wrote in the chat. But someone said PR, Mashal. And can you tell us why you thought this is PR? So PR has specific histological features that I wouldn't say each of them is specific, but when they occur together, they're kind of characteristic. And we see all of them here. So we have, like Michelle said, there are RBCs in the dermis. As you can see here, the scatter of RBCs, that is one. Perivascular infiltrate, which is not very specific, but we can see it here. Spongiosis, which is more in certain foci. So you can see a focal spongiosis in some areas and less spongiosis in others. And you can see the mounds of parakeratosis, very distinctive of pityriasis rosea. As you can see, little mound here, little mounds of, or like, little hills or mounds of parakeratosis, which is very distinctive for pityriasis rosea. Okay, but in the end, you always have to correlate it with what you see clinically. Moving next here. This is a case where we can see there is from this power, you can tell that there is parakeratotic stratum corneum and neutrophilic crust. So neutrophilic parakeratosis, which is distinctively involving the perifollicular area, which we call shoulder parakeratosis, and a little bit spongiosis, which is also mostly around the hair follicle. Can anyone tell me what this is? And we have a very large terminal hair follicle and multiple, so you can tell that this is either on the scalp or in and somewhere else in the head and neck area. what kind of spongiotic or psoriasiform condition or overlap between the two this is this? No one's answering. Okay, this is seborrheic dermatitis. Seborrheic dermatitis has psoriasiform and spongiotic features, and what distinguishes it from the other two is that it has perikeratosis and neutrophilic crust right next to the hair follicle, as you can see here. Moving on to the next patient. What do we see here? Let's focus a little bit on the stratum corneum. It has a very nice distribution of its perikeratosis and orthokeratosis. What are we talking about here? MK, very good. Pityriasis rubra pilaris, the checkerboard perikeratosis, as you can see here. If you go back to the dermatologists, very often they compare it to psoriasis, but if you ask me, they cannot be more different in terms of histology. So if you remember, psoriasis has a club-shaped regular retiridges, which we do not see here. Some areas are longer, some areas are shorter, some areas are thicker, some areas are thinner. The stratum corneum, by definition, in PRP would never have, not by definition, but like it almost never has neutrophils, so they would never find a neutrophilic perikeratosis in PRP. So you won't find any not only in the stratum corneum, even in the epidermis, you're not going to find your mono microabscesses or spongiform pustules of Koyai. And in the end, another feature that I do not see it in this particular slide, but it's quite often seen in PRP, is acantholysis as well. Acantholysis is a common feature in PRP, and it's usually focal and not consequential, doesn't lead to any blisters or anything, but you would see acantholysis often in PRP. Moving on to our next slide. What can you see here? These conditions are very old. This is a group of conditions that is very often described as psoriasiform, which what you can see here. Let's see, someone answered in the nutritional dermatosis, which is correct, which can be seen in pellagra, Chondrodermatitis enteropathica, and many other conditions that are nutritional, and can also be seen in glucagonoma. So we can see here some beginning of a psoriasiform horn. If you can see in the lower areas, the stratum corneum is starting to be confluently perikeratotic. There's regular club-shaped retiridges and an acanthotic epidermis. But what is striking here is the pallor of the upper layers of the epidermis, which is quite distinctive. Quite a distinctive finding you would see in nutritional dermatosis. Let's go on to the next patient. What do we see here? Come on, guys! I can't hear your voices. I feel like I'm alone here. So Michel, I wish Michel had a mic. I would like to hear his voice answering all these questions. So he's correct with this answer. So LP, Lichen Planus. So this is kind of straightforward, but I used this slide not to examine as much as to show you all the different features that you would see in Lichen Planus, which I actually see most of them here. So you got your areas of wedge-shaped hypergranulosis, as you can see here. The stratum corneum is thick, compact with no perikeratosis. That I can tell you is by definition, unless it's oral or hypertrophic or drug-induced, not hypertrophic, oral or drug-induced Lichen Planus. See here the granular layer, how thick it is in some areas, and the sawtoothing of the retiridges, as you can see here. You got your Max Joseph space. You got your colloid and sevat bodies, as you can see here from the necrotic keratinocytes. Many features of Lichen Planus, but what defines Lichen Planus definitely is the interface lichenoid dermatitis that we can see here. So interface dermatitis is when there's an inflammation at the interface between the epidermis and dermis. There are several ways of classifying them, but Bernie Ackerman proposed the vacuolar versus lichenoid method, which, although not perfect, but is a good way to differentiate the two groups. So the lichenoid interface dermatitis, I mean, by the way, so the lichenoid and vacuolar can overlap a lot, but we use the term lichenoid or vacuolar depending on what we see more than the other. So when we see a lot of a huge band-like infiltrate, thick band-like infiltrate hugging the epidermis, we call it more lichenoid. If we see less of a band-like infiltrate and more vacuolar degeneration of the basal layer, we'd call it a vacuolar interface. Okay, so for example, here in Lichen planus, we do see vacuolar degeneration, but not as much as we see a striking lichenoid infiltrate. So it all depends on what strikes you first when you see the entity. So here, this is Lichen planus. Okay, moving on to the next patient, or next slide. What can we see here? So Lichen nitidus, that is very good. Ghassan, MK, and Mishal, who said nitidus only. He wants to save time, doesn't want to type for very long. I respect that. So Lichen nitidus, you all know it from the books that as a condition where it's focal and has you know, the ball and claw pattern, if you like the terms. So it looks like a ball of infiltrate with the epidermis clawing up to contain it. These features are, yes, distinctive, and always remember the ball should not be really large. It's like maximum a couple of rete ridges in width. But there are two other features that I wanted you to be aware of with lichen nitidus that's not very often described, but like you see them in almost every case. Is number one, the focal perikeratosis above it. So the whole lesion we're not gonna have perikeratosis. Just above the ball, you're going to see this area of perikeratosis. That's one distinctive feature. The other distinctive feature is the cellular composition. Yes, we do see a lot of lymphocytes, but in addition to the lymphocytes, we see a lot of histiocytes here. And in some cases, as you can see here, there's giant cells, which actually pushes many people to classify this condition not under the lichenoid disorders, but under the granulomatous disorders. So I like to always think of this entity as something in the fringes between a lichenoid disorder and a granulomatous disorder. So these are the features you would see with lichen nitidus. Let's go next. What do you see here? Another kind of interface dermatitis. Is this more lichenoid or is this more vacuolar? You can see again here lots of colloid and sebaceous bodies, and more or less of a band-like infiltrate over here. So this is lichenoid. So and you know me, I'm not going to repeat to you a slide. I'm not going to show you another lichen planus. Let's go a little bit deep. Let's go a little down. What's going on here? Remember from the normal skin lecture, we're talking about here the eccrine glands. So this is lichen striatus. Very good. So this is lichen striatus. Another distinguishing feature of lichen striatus, other than the fact that it has a deep infiltrate, something that the other lichenoid disorders don't usually do is spongiosis. Lichen striatus very often has also spongiosis, which reflects sometimes in its clinical appearance. When you see lichen striatus, very often it has this more or less spongiotic look compared to other lichenoid disorders. Let's move on. This is very striking here. The band-like infiltrate is there, but it's pushed down by something else. So this is LSNA, lichen sclerosis and atrophicus. So what you can see here is the thickened compact stratum corneum. You got your atrophic epidermis, you got your hyalinized dermis below it, and you got your band of lymphocytes below all of that. Another feature you would see, and it's not in this case, but you would see commonly in extragenital lichen sclerosis, is follicular plugging, which again, we don't see it here, but you would expect to see it in extragenital LSNA. Let's move on. What do we see here? Let's go closer, power. What's going on here? Look at the basal layer. So there is necrosis in the epidermis, yes, but what's going on in the basal layer? Look at all these. What's all that? The vacuole. So there's a vacuolar degeneration in the basal layer. Very little infiltrate compared to what we saw earlier, and there's a lot of death and squalor in the epidermis without a huge infiltrate. So this is a vacuolar interface dermatitis, and when we talk about Lichen planus as the prototype of the lichenoid interface dermatitis, we would definitely consider EM, SGS, and 10 as the prototypes of the vacuolar interface dermatitis, and this is this is a case of either EM, SGS, or 10. It all depends on the clinical picture of the patient. Histology, they can look very much the same. Moving on to the next. This one you don't need high power to diagnose. What do you guys think? Someone said DLE. Does anyone have other ideas? LPP from M. Okay, so why could this be? Why is this DLE more likely than LPP? So first of all, let's dissect this slide. I think let's go here as well. I like this area better. So first of all, there's thinning of the epidermis, which would go more with the lupus. There is a perifollicular infiltrate. So again, when it's high, I would say that it could be both. But when the infiltrate goes really deep into the follicle and really deep into the blood vessels, it would be more likely to be DLE. Over here, MK says mucin. I can't tell you that this is actually not, but this is more of solar elastosis here. But what the white spaces in between them, I can assure you that when we stain it with a mucin stain, it is going to light up blue. So yes, mucin would be a good feature to make us aware that this is a process of DLE more than Lichen planus. And again here, look at this inflammation around the eccrine gland or duct. So perifollicular periadnexal infiltrate with the atrophy of the epidermis are all features that make it much more likely to be discoid lupus. And then this thing as well. Look at how dilated the follicle and plugged it is. You're not going to see that as often with Lichen planus as much as lupus. Yes, you can have follicular plugging, but this pattern of plugging is more with the discoid lupus, this large plugging with deep infiltrate. If you see smaller plugging with a superficial infiltrate, you can see it with the Lichen planus. With the deeper plugging, the deeper infiltrate with the large plugging would go more with the discoid lupus. Dermatomyositis is a similar, and you can see here there's still interface dermatitis with vacuolar degeneration. Dermatomyositis has very similar features to lupus, but the difference is that there would be much less, let's say, much less pronounced. I would say the infiltrate is usually less in severity. Especially the periadnexal and perifollicular would be less. Another feature that I'm actually seeing here that I didn't mention it earlier, if you can see here, the basement membrane is quite thickened, and this is much more likely to be seen with the discoid lupus than any other kind of lupus and or dermatomyositis. Okay, a good way to differentiate between lupus and dermatomyositis on histology would be immunofluorescence. Discoid lupus would have the positive lupus band with IgG, IgA, IgM, and C3, and dermatomyositis will not. If your lab has the membrane attack complex immunohistochemistry, that would be positive with the dermatomyositis. Next, what do we see here? So we have a interface dermatitis, strongly vacuolar interface dermatitis. But what we can see here is the two contrasting signs. What we see here, So Ghassan, he says EM. It could be EM, yes, but again, you can see the necrosis of keratinocytes. So this could be an early EM, yes, but there's something that we might have to notice. First of all, we have an acute stratum corneum. See, it's very normal. But on the other side, we see a lot of old features, which is pigment incontinence. So the epidermis is telling us that the stratum corneum is telling us no, there's something new going on. But the dermis is telling me no, this thing has happened before, and we are the signs of that thing. So this is something that keeps recurring in the same location. And what the interface condition can keep recurring in the same condition? That's fixed drug eruption. That's correct, Mishal. And the infiltrate, usually in the dermis, it will be mixed. There will be lymphocytes. There will be eosinophils. As you can see here, this is eosinophil here. So there will be eosinophils. Again, another one here. Lymphocytes and sometimes even neutrophils. And the infiltrate tends to be superficial and a little bit deep compared to erythema multiforme. Okay, let's move on to the next slide. What are we looking at here? What I can see, first of all, is from low power, a wedge-shaped infiltrate, superficial and deep. There is a perikeratotic stratum corneum. There is a lot of necrosis within the epidermis, a lot of dyskeratotic cells, strong interface dermatitis, and an intense superficial and deep perivascular lymphocytic infiltrate. Some loss of blood is going on there as well. And yes, these are features of psoriasis lichenoides, Iperiform acuta. PLC, which is the chronic form, would have much less pronounced infiltrate. It will have interface dermatitis, but it's much less likely to have wedge shape, much less likely to have neutrophils in the stratum on the top of the epidermis and the stratum corneum, as you can see here. And the inflammation is much less pronounced than with the pleva. Next, what's going on here? You guys are pretty quiet today. Where is Ruth? She's usually very outspoken during the lectures, and she used to answer all the questions. And today she's very quiet. So what's going on here? This blood vessel, I can see endothelial swelling, fibrinoid degeneration inside the blood vessel, a lot of bleeding outside, a lot of neutrophils that are disintegrating, causing a nuclear dust. Again, swelling of the endothelial cells, a lot of perivascular infiltrate, disintegration of the neutrophils. This is leukocytoclastic vasculitis, correct? So this is LCV, leukocytoclastic vasculitis. The cause of leukocytoclastic vasculitis is dependent on clinical, of course. Moving on to the next case, which we can see here, pretty much normal epidermis and dermis, but something's going on here in the dermis. What is this? So we see again leukocytoclastic vasculitis involving a large subcutaneous vessel. So Ruth says this is PAN. And why is this PAN and not panniculitis, for example? Like why is it not erythema induratum, for example? Why is I mean, I agree this is pan, but why? So if you can see here, especially in the other sections, away from the blood vessel that's inflamed, the fat is pretty much normal. Even here, you can see some inflammation around the vessel, but the rest of the fat is pretty intact. This is a feature that strongly supports that this is primarily a vascular inflammation, and this is polyarteritis nodosum, and this is not erythema induratum of Basel, which would also very often have initially as leukocytoclastic vasculitis that would turn into a granulomatous vasculitis. But from the beginning, you would see that the infiltrate would go all the way and then strongly involve and destroy the subcutaneous fat. Okay, moving on to the next slide. If you guys can have any questions, you can stop me at any at any point, please. So yeah, let's move on here. What do we see here? We see also another leukocytoclastic vasculitis. But in addition to the leukocytoclastic vasculitis, we have a lot of eosinophils, and we have this thing. What do you call this, and what do you call this condition? This is flame figure. That's correct, Michelle. So what kind of leukocytoclastic vasculitis would have a lot of eosinophils and would have a lot of Wells syndrome is not a vasculitis. So yes, when you see flame figures, you would see it with Wells, but you would not. It's not distinctive for that drug. I can't tell you that it couldn't cause it, but there's something else that is much more likely and much more characteristic to have a strongly eosinophilic, like diffuse. First of all, diffuse eosinophils in the dermis, not just around the vessels. Eosinophilic leukocytoclastic vasculitis and flame figures. These features we see them very often with Churg-Strauss syndrome or eosinophilic granulomatosis with polyangiitis. So these are features of Churg-Strauss. Okay. So if you have any question about any of these things, let me know. I just have to move on a little faster so that we can finish all the slides. So what's going on here? Again, I see a vasculitis, but inside the vessel, there's this like pinkish jelly material in many of the blood vessels, and almost all of them. You can see this pinkish jellyish material inside all the blood vessels that is associated with the vasculitis. So, Michelle, definitely not cryo 1, because cryo 1 will not cause a vasculitis by definition. I'm being a little hard on Michelle because he's really smart, so I expect so much from Michelle. So you wanna correct your answer, because type cryoglobulinemia is usually the one that is vaso-occlusive. So mixed cryoglobulinemia, that is correct. Mixed cryoglobulinemia. Is there a chance my audio is not working because I can't hear any of your voices? Can anyone tell me anything so that I just make sure that I can actually hear you?
Yeah, we hear you.
Oh, okay, good. Because I couldn't hear anyone. I thought maybe there was a problem with my audio. Okay, so this is mixed cryoglobulinemia. So if you can see here, there's cryoglobulins and vasculitis. But don't get me wrong. This is just a, let's say, a classical image. It's not a common image. When you see cryoglobulinemic vasculitis, you would see a normal leukocytoclastic vasculitis, and not always would you find the cryoglobulins inside the vessels. When you find them, it usually correlates with more severe clinical picture. Moving on. This is one of my favorite vasculitic processes, and you can diagnose it as a very low power. So this is a vasculitis, but it has a very nice storiform fibrotic nodules, and this occurs in the elbows and the knuckles. This is EED, correct? Very good, Hassan. This is EED. If you can see closer power, you can see there's a vasculitis going on. There's a lot of neutrophils. But when you go back in higher power, in lower power, you can see all these fibrotic nodules, which are storiform, and a very distinctive Gren zone, which does not have to be there, but it's interesting to see, especially for EED. It does not have to be there, but very often it's there. Okay, wonderful. Let's move on here. This one, if I tell you, this is a vasculitis, and at low power, you'll be able to diagnose it based on not what we see here, based on what we see here. This is Granuloma faciale, very good, which is, again, has a very nice Gren zone. If we had time, I would have told you the whole story behind why we call it a Gren zone, but we don't have time right now. So vasculitis, and Dr. Elson likes to call it a party where everyone's invited, because you can see lymphocytes, you can see histiocytes, you can see eosinophils, you can see neutrophils. Everyone's there. So that's nice, except plasma cells. I don't usually see very much plasma cells here. So yeah. Okay, moving on. What is this condition? Another inflammatory disorder.
This is GA.
This is GA, very good. Granuloma annulari, and even here, like without the mucin stain, I can see the mucin in the center with necrobiosis and a lot of histiocytes palisading around the necrobiotic area. So this is a feature. These are features of granuloma annulari. But I'll skip quickly and see here. What do we see here? Can anyone tell me what's going on here? So these cells are histiocytes. And so yeah, interstitial granulomatous dermatitis, or what I actually like to call interstitial granuloma annulari. Look, in the exams, 99% of, or at least 90% of GA is going to be this, and 10% is going to be the interstitial type. But believe it or not, in real life, 90% of granuloma annularis I see is this, and only 10% is this, actually. So in real life, we almost always see interstitial granuloma annulari and not the palisading classic type. Very often we see the interstitial type, which is initially very hard to diagnose, but a mucin stain would be very helpful here, which would highlight highlight the mucin stain. I mean, would highlight the mucin in the dermis. So interstitial GA, you can see here a lot of histiocytes, and they're not perivascular. They're just between the collagen, like forming like strings of histiocytes all over the dermis. So interstitial GA over here. Moving on next. This is also a low power diagnosis. You can see a lot of necrobiosis in the dermis first and in the subcutis. And you can see from this power, you can see this grayish outline of the infiltrate will tell you that these are more like histiocytes rather than neutrophils, eosinophils, or lymphocytes. So this is necrobiosis lipoidica. Some would like to add diabeticorum, but that's controversial. So yes, this is NL or NLD. Very good. Let's move on to the next because we're pretty short on time. Look here. So there's a sea of histiocytes, and some of the histiocytes have this very cute arrangement with a little foam around it. Here, very circular here, with a little bit foam around it. So someone said something I didn't hear.
Some giant cells?
Some giant cells, yes, but they're a specific type of giant cells.
Two-ton giant cells.
These are two-ton giant cells. And where do you see two-ton giant cells?
GXG.
So and there's other conditions where you would see two-ton giant cells, but this is definitely a case of GXG. You see no necrosis in the dermis. All you can see is diffuse histiocytes with these two-ton giant cells with a foam around them. So this is a juvenile xanthogranuloma. Very good. This is another condition. There's a lot of necrosis in the dermis. And again, I see my two-ton giant cells again here. But what's different here is that these two-ton giant cells can be really large and with necrosis in the dermis. And let me see if I can see that feature here. No, that's not it. So yeah, this is NXG, necrobiotic xanthogranuloma. It can have really large histiocytes. What differentiates this from NLD is that sometimes actually it's very hard to distinguish. First of all, clinically, you need to be aware that NXG is mostly on the lower extremities, and not NXG, NLD is usually on the lower extremities, and NXG is usually on the head and neck. But then again, that can differ. Sometimes you can get NLD in the head and neck, and you can get NXG anywhere else in the body. So that's definitely not the only way to differentiate the two. Another feature that would make this more likely to be NXG is that there's an overabundance of giant cells and two-ton giant cells. Those would be more likely to be seen in NXG rather than NLD. Plasma cells are more likely to be seen in NLD than NXG, so that's something for the other team. NXG, I mean, I don't see it here, to be honest, but if you go to the subcutaneous fat, usually NXG is so confluent, it's so large, and it definitely in most cases involves the subcutaneous fat. And in the subcutaneous fat, if we had it here, you would see the fat clefts that you wouldn't usually see in NLD. So these features are used to distinguish the two, but definitely it's very hard to sometimes distinguish the two. And sometimes you need to know the clinical history of the patient, like for example the location, the age of the patient, and you can test for gammopathy in the patient, which would go more with NXG. Okay, next slide. What do we see here? Can anyone tell me what's going on here? Look at these giant cells. Disorganized, not very good looking, like the two-ton giant cells or the Langhans giant cells that we usually like to see in sarcoids and NXG. So disorganized. So tattoo granuloma, that is correct. And to just broadly classify it, this is a foreign body granuloma. And yes, you are correct, MK. This is a foreign body reaction to a tattoo. So this is another kind of granuloma, which is a foreign body granuloma. And last but not least, for our final slide today, when we talk about granulomas, this is the queen of granulomas. What is this? Very small, small. Sarcoidosis, correct. So sarcoidosis, not only is it distinguished by its small granulomas, they are quite naked granulomas. They can have giant cells, definitely. They're Langhans giant cells, as you can see, they're horseshoe shaped. They look a lot like the two-ton giant cells, but they don't usually have foam around the cytoplasm. There's not much lymphocytes around it, around the infiltrates, as you can see here, the naked granulomas. Yeah, so this is a case of sarcoidosis. Since we have a few more minutes and we can get Dr. Alva to start preparing her slides, can anyone tell me any questions you have for today? Since we had a huge dose of me talking a lot and you talking very little today, does anyone have any questions? You can post it either in the chat or spit it out in the audio. Okay, great. So no one has any questions. So I guess we can. We still have a minute or two to start. So if you really don't have any questions, we can. Okay, I can again re-emphasize on the survey that we posted. Dr. Lova mentioned it earlier, but again, I would re-emphasize on you please doing that because and then in the end, you know, the better you can guide us to helping you, the better education you guys are going to get, and the better lectures you can get delivered to you guys. So yeah. Okay, let's move on to our next talk.
So hi again, can everybody see my slides? Just to make sure that everybody can see my slide. Yes, okay. So I'll do a couple of brainstorming cases to work your mind through. It's a kind of a type of an MCQ basis, similar to what you will get in the exams. So let's start. Okay. So the first one is a 13-year-old boy present to his doctor with a circumscribed scaly plaque on his scalp. His palm appears somewhat shiny and show an orange hue. Okay, so I will present the slides. And as I told you before, take your time with each slide from low power to higher power. Think in a systemic way as you approach your diagnosis. Please just keep your mic muted. So, okay, perfect. Okay. Think in a systemic way. Work through from the epidermis all the way to the dermis. Can go back and then show it one more time. Okay. So what is your diagnosis? Psoriasis, Pityriasis rubra-pilaris, seborrheic dermatitis, Pityriasis rosea, palmoplantar keratoderma. Wow, there we get all the correct answer. Yes, it is Pityriasis rubra-pilaris, as Dr. Amin discussed it. Though you will notice within even the first slide, you will notice the discrete foci of parakeratosis alternating with the orthokeratosis on this slide, and both in a horizontal and vertical fashion, like a checkerboard kind of fashion, as Dr. Amin mentioned, with the shoulder parakeratosis, meaning that the parakeratosis mount the edge of the follicular ostia, the keratin plug fill the ostia itself, even the epidermis show the irregular psoriasiform hyperplasia. Okay. The rete ridges, as you see here, it's not that much elongated as in psoriasis, as we mentioned it before as well, and the absence of neutrophil microabscess that making the choices of psoriasis is less likely. Okay, so we get our answer of Pityriasis rubra-pilaris. Okay, up to the second case. A middle-aged woman present to her doctor with a thickened plaque on her neck. She said that she noticed it after wearing a necklace. I'm giving you a hint with the history even. So work through the slides, low power, bit higher power. So what is the most likely diagnosis? So is it a chronic contact dermatitis? Is it an arthropod infestation? Is it psoriasis, atopic dermatitis, lichen simplex chronicus? You want to have a look one more time. See the epidermis? Then walk through with the inflammatory, infiltrate. And most of the answer is A, and yes, that is a correct answer. It's a chronic contact dermatitis. So how do you differentiate between an acute or a chronic? So as Dr. Amin mentioned it earlier before, so usually the acute will be recognized with much of the marked intraepidermal edema. You will see much of the spongiosis. Then even it will form a vesicle or even bulla, which clinically will look like a blister. And usually it is associated with the intraepidermal neutrophil, and you can see eosinophils as well with the acute. Even the superficial epidermis will have a mild edema, and the lymphocyte will be the predominant. While the lesion will progress all the way to the chronic, the spongiosis will subside. It still will be there, but it will subside little bit and will have an intracellular spaces, the widening of intracellular spaces. And the inflammation is a bit milder, but similar component to the acute. As we see here from this diagram, which show very nicely, going all the way from the acute to the chronic inflammation, how the spongiosis go, how the inflammatory cell, how the rete ridges is forming, all the way to the chronic inflammation with a little bit of the elongation of the rete ridges as you go all the way to the lichen sclerosis. Okay. Okay, so our third case is a 25 years old man present to his doctor with a painful bluish lesion with a central punctum on his leg. Okay. Bit higher power. You can appreciate a bit of spondiosis. And the inflammation. So what is your diagnosis? Is it a sweet syndrome, bioderma gangrenosum, primary vasculitis, progenic or biogenic granuloma, and spider bite? You can just shout the answer or write the answer in the chat box. You want me to go back one more time? They say that Dr. Amin haven't discussed this. And yes, E is the correct answer. It's a spider bite. And usually there are some of the spider bite that can bite the human. And the most important one is the brown reculase spider, which found in the south central of US. The bite usually starts as a very painful and bluish, can be a macule, papule, nodule, with the central punctum is usually seen in the clinical picture as well. And even some of the patient may progress to blistering, ulceration, and even necrosis of the lesion itself. Okay, and usually they will have some kind of systemic symptoms as well with the fever, malaise, okay. Well, the histo part of the spider bite is quite non-specific, but we can appreciate even here on the lower power, we can appreciate the tissue necrosis with the thrombosis and the vascular injury with a bit of eosinophils, variable number of eosinophils in up here in this picture. So you can see the variable number of eosinophils, the pandermal infiltrate, it can contain the lymphocyte as well, the neutrophil, the eosinophil, which is very important. And even the epidermal feature of spongiosis and acanthosis, and the marked dermal edema. You can see it up here, the marked dermal edema. Okay, so that was a spider bite. So that is with the staining. You have to know your staining. Don't forget your staining. So all the stain used to stain mucin except leather, alchina blue, mucocarine, colloidal iron, pass. What do you think? Which one does not stain mucin except? You have to concentrate on the question, except. Yes, we got Dr. Ghassan and Dr. Mishal. Leather is a correct answer because leather, what does it stain? Yes, leather stain mast cell. This is very important, very important. Okay, up into our fifth case. A 55-year-old man present to his dermatologist with a crusted, centrally ulcerated, painful lesion on the tip of his ear. Sorry, the top of his ear. Okay, so this is the low power. Did anybody know it from this kind of spot diagnosis? Would be very difficult. Okay, let's see. But higher power. Okay, what is your diagnosis? Is it perforating collagenoses, chondrodermatitis, factious dermatitis, actinic keratosis, squamous cell carcinoma? Okay, and yes, you get the correct answer. It's chondrodermatitis. That is correct. And you know, usually chondrodermatitis, they present as a small, and usually it's a dome-shaped, very painful papule, and you found in the ear. They often ulcerate with a firm crust, and histologically they are very characteristic. You can see it is even from the low power like that, you can diagnose it as chondrodermatitis. Because it shows the central crater-like ulceration containing the keratinous depress. The edge and the base of the ulceration contain the granulation tissue admixed with the inflammatory cell. You can see lots of inflammatory cell up here. And the dermal collagen is even more eosinophilic and show the fibrinoid degeneration. You can see the necrosis as well. Up here, okay. How do you remove it? So what is the treatment option? You can remove it actually surgically, but they have a risk for recurrence by 15 to 20%. Okay. So what is stain used for granular cell tumor? you see it in the picture, and you know that granular cell tumor usually they present as a solitary skin-colored dermal papule, and they occur on the tongue. So which stain do we use for granular cell tumor? Is it MART1? Is 100 Gemza Congo red Bancosa? Have to know your stain. That is a very important part of histology. So we get only Dr. Mish'al. That is a correct answer, Dr. Mish'al. S100 is a correct answer because MART1 we use it for melanocyte. Gemza we use Gemza for, anybody know Gemza we use Gemza for staining what? Which cell? You are a bit not that much interactive this session. Okay, we'll use Gemza for mast cell and we use Congo red for amyloid. Okay, and that's it. And that's the end of a presentation. So hope everybody like the kind of a quiz-like MCQ, which is really important just to refresh your mind. And some of them are spot diagnosis like. Thank you all, and don't forget to do the survey, and you can join the Microsoft Teams as well. I'll post the quizzes out there so you can go and review them again, and later on maybe we can add the videos of the lectures as well. Anybody can post some interesting articles, can join discussion as well. So thank you all. And we'll see you in 2 weeks' time.